The following audio-supported podcast is intended for informational and educational purposes only and is not intended as medical advice. Please speak with your healthcare professional before making any treatment decisions. The guests on today's show were paid to participate in this podcast.
Hey Thal Pals, it's your fellow patient advocate, NinaMaria again, and I'm here with co-host Dr. Kevin Kuo. You're listening to Thal Pals, the Alpha Beta Revolution, Season 2. All right, we're back again, and on today's episode, we're talking lab tests. As much as we'd like to squeeze this one all into one tight little episode, we're making it a two-part series because it encompasses so much important material, and we want to do it the justice it deserves. So let's kick off part one of lab tests with our expert on the topic, Dr. Kevin Kuo, aka my co-host. Hey, Kevin.
Hey, NinaMaria. How are you?
I'm great and super excited for this episode. How are you?
Very good. Me too. I'm glad we're here together again today. Let's get going.
Agios is a biopharmaceutical company that's fueled by connections with patient communities, healthcare professionals, patients, and each other. Building on these connections and the company's unmatched leadership in the field of cellular metabolism, Agios is pioneering therapies of genetically defined diseases, a broad group of rare and more common diseases that are typically severe and life-threatening. Near term, Agios is focusing on hemolytic and acquired anemias, including sickle cell disease, pyruvate kinase or PK deficiency, and thalassemia. To learn more, visit agios.com. That's agios.com.
There are a number of tests that healthcare providers usually ask for when treating people who have thalassemia. And today we're going to talk about two very important ones, hemoglobin and ferritin. So let's kick it off with a very important lab, hemoglobin. What is hemoglobin for those of us who are not familiar?
So hemoglobin, as many people know, is a very important protein inside the red blood cell that carries oxygen. So obviously, this is one of the most important laboratory parameters that we look at for anyone with anemia, especially in thalassemia. When hemoglobin is low, of course, then one needs transfusion because then you need enough oxygen carrying capacity to deliver the oxygen to the essential organs. Now, when we look at the number hemoglobin, I think is important for people to think about the context, meaning that why was this blood drawn? Why did we measure it? And by knowing why it was drawn and the circumstances, then that would be the first step for us to interpreting it.
So for those of us living with thalassemia, what do we need to know about hemoglobin? What's important for us to take note of?
Those who are on transfusions, I think we need to know whether it was drawn before or after transfusion and the timing. And also we have to realize that inherently the machines that measures the hemoglobin has certain variance onto it, meaning that even with the same sample drawn on the same day from the same person, the number can vary quite a bit because machines are just machines. They're not perfect, right? And once we realize that, then it's important that we know what the number is, but we shouldn't get too hung up exactly whether it's like 9.7 or 9.9 or maybe even 9.5. The natural variance is around 0.5 grams per deciliter, meaning that again, from the same sample, same person, same date, same time, the first draw could show that the hemoglobin is 9.5. The next draw can very well be 10.0 or 9.0. And it basically means the same thing. So when we think about numbers, we've got to think about, is it in the ballpark range? And also, is this a range that I'm used to? Because for different people, their transfusion target is different. Some people like it higher, some people like it lower, right? Again, no one size fits all. It's like shoes, right? Different kinds of shoes, different styles, and different sizes.
Okay, so since we're talking about numbers, and like you said, they can fluctuate so much, what should we be paying attention to other than numbers?
The general trend. When we think about numbers, is this your quote-unquote usual range? And are we talking about whether it is trending higher, trending lower? And what's the change as well? Is the numbers changing very rapidly? If, say, on the last transfusion, your hemoglobin is sitting at 9.5, and now it suddenly drops to 6.5, obviously, that is not normal, right? Because that is not your usual trend. And that's when the doctors, the healthcare provider, will start investigating, finding out why there was that sudden drop. On the other hand, if say your last value was 9.5 and today comes back as 9.2, I personally think that we really shouldn't be sweating about it because it's within that error range and it's pretty much the same.
Okay, so I guess something we should be looking at is that it's consistent from month to month or however often that we're taking that level.
Well said.
All right, love it. For us Thal Pals, some of us are transfusion dependent, meaning we depend on regular transfusions to thrive with thalassemia. And there are those of us who are non-transfusion dependent who do not rely on those regular transfusions. So how does hemoglobin differ between those two groups?
In those who are non-transfusion dependent, we see a much wider range because they're not on transfusions. And even within the person, there could be a lot of variations as well. If a person is sick, for example, let's say you caught a cold or that you recently had surgery, the number can be surprisingly lower than what the usual number is. And this is true for both transfusion dependent and non-transfusion dependent thalassemic patients, but more so in the non-transfusion dependent because they're not on transfusions, right? If you're on transfusions, the doctor can often make up the difference by giving you more blood or by reducing the amount of blood that you need. In the non-transfusion dependent patients, they don't necessarily have that option, or the doctors are not checking the results as frequently. And so sometimes we see that differences. And then again, I think looking at the historic trends is important, right? If your historic trend has always been, say, between 7 and 9, and then suddenly your hemoglobin drops to 5 or 6, so obviously that's an issue. On the other hand, if your hemoglobin is 7.2, but your last one is 8.5, you're still within that sort of historical range of yours of between 7 and 9. And so I think there's less of a need to find out what the cause is. But I think regardless, the patients often have excellent sixth sense, right? They know that something is going on in their body and they're not feeling right. And if that's the case, always mention it to your doctor, right? And then your doctor can investigate and take that into context. And then another important thing about interpreting numbers or hemoglobin or just numbers in general is that we need to take the person into context. What's happening to the person right now, what has happened to them in the recent months or even days leading up to the transfusion or leading up to the drawing of that sample. And then what are we planning to do in the future? If, say, you're planning on a trip to go to the Caribbean and you're planning to go there for 4 weeks, your transfusion schedule is exactly 4 weeks, we may have to consider a higher hemoglobin for you so that you feel more energetic, you feel better when you're going on vacation. And often my patients would request that. And I say, okay, no problem. Your iron looks good. You can afford to get an extra unit. Go enjoy yourselves. On the other hand, sometimes we have to be a little more restrictive for whatever reason in terms of the transfusion. And we have to pay a little closer attention to the numbers.
I know you said there isn't a perfect number and it's not a one size fits all. Are there any numbers or ranges that we should be aware of that aren't good for patients?
The Thalassemia International Federation, they have guidelines for us as clinicians to work with. So they have guidelines for both transfusion-dependent and non-transfusion-dependent thalassemic patients. And for transfusion-dependent thalassemic patients, they generally recommend a range between 9 and 11 of pre-transfusion hemoglobin. So that we as doctors usually use that as a guide in terms of transfusing patients.
So you were talking about these numbers and how we monitor ourselves and patients specifically. Why is it so important to monitor these numbers?
The numbers themselves are not necessarily important, but what are we doing with the numbers, right? I think that's more the issue at hand. And what it is that when we are able to achieve a certain hemoglobin, we are able to prevent a lot of the complications from the thalassemia. And specifically, the reason why Thalassemia International Federation recommends hemoglobin between 9 and 11 is so that we can prevent these complications. For example, the changes in the bones that some people with thalassemia can experience if they're not getting enough transfusions. There's these things called extramedullary hematopoiesis, leg ulcers. There's a disease called pulmonary hypertension, and we want to prevent these complications from happening. And this is why we do what we do. So again, when we aim for these numbers, we're not aiming just because we want to achieve that particular number. It serves a purpose. Having said that, even when we achieve that particular number, sometimes there are patients who still have these complications, and then we need to go out of range. We need to go out of the suggested range and then give even a little more blood. And then in some cases, again, depending on availability of blood and donor availability, whether there is any antibodies, for example, we may have to consider less blood.
So is there a certain amount of time that a patient has when these things start to occur? Is there reversing? Is it only prevention? Is there a time period in which, okay, these things are starting to happen, we have red flags? How do we revert?
Obviously, the more consistent you are with transfusion, the more consistent you are with monitoring your blood work and so forth, that's usually better. There's no particular time in which they come up, meaning that it's not like you miss one transfusion or you postpone your transfusion for the week or 2 weeks and then suddenly these complications are going to pop up. So rest assured that's not going to happen. But it's again about an overall long-term consistency. If someone's able to maintain consistency over a long term, then they're not going to see these complications that are happening. If over a long periods of time people are inconsistent, then these complications can occur.
And I think by now we all know that I'm an advocate of self-monitoring and knowing your body, listening to your body. So aside from the numbers and the things that our doctors are looking at, is there anything that patients can be aware of and be monitoring, any kinds of symptoms or things of that sort that we can pay attention to be in sync with our bodies and keep an eye on our hemoglobin?
Absolutely. I think being able to plan in advance is always a good idea, meaning that if you have upcoming trips, if you have upcoming events or anything like that could potentially be stressful for you, mention it to your doctor so we can plan your transfusions accordingly. Oh yeah, the other thing, of course, is be mindful of the fact that when you feel fatigue, it doesn't always correspond to the hemoglobin. We would like to think that anemia plays a huge role in fatigue and shortness of breath and so forth, but it doesn't necessarily have to be, meaning that there's many different causes of fatigue. There's many different causes of shortness of breath. It's very important that you mention the symptoms to your doctor so that your doctor can then interpret the numbers in that context, right? Often I would have patients who tell me, I can't believe my hemoglobin is 11. I am so tired and so out of breath. I don't understand why. And then when you dig deeper, you find out that, oh, you know what, so and so is actually undergoing their final exam. They're actually not sleeping well. They're going to bed at 1 o'clock in the morning and they're eating chicken ramen for dinner, not having a proper meal. And then you're like, oh, of course, there's good reasons for being tired. You don't have to have thalassemia to be tired if you're going to bed at 1 o'clock in the morning and you're only having one meal a day.
Kevin, that is so relatable because I feel as though anytime I'm tired, maybe one day or for consecutive days, I immediately want to blame the hemoglobin. I'm like, oh, I must be low. And there have been times where, lo and behold, I go to get my transfusion, I get my labs back, and I'm like, there's no way I'm 10, right? Like, no way, it's wrong. But no, because there's so many other factors in how our body reacts. It's so easy to blame the hemoglobin, even though, like you said, there's things like sleep and nutrition and stress. We just touched that there are things that impact how we feel and our fatigue. Are there other outside factors that impact hemoglobin?
Hydration is key. So a lot of times, again, people will feel very tired and stressed out and say, how come my hemoglobin is 11.4? It doesn't make sense to me. I'm drained. And then you examine them and then I'm glad to see you're drinking right now. And then you see their lips are all dry and their eyes are sunken. And you're like, you're not having enough water. And when you don't have enough water, then your hemoglobin becomes concentrated. It's like trying to make a Kool-Aid drink, but not you add enough powder, but you don't add enough water to mix it. It becomes really thick.
I did not know that.
Yeah. So if there's one advice I can give to everybody who's listening to Thal Pals right now, regardless of whether you have thalassemia or not, drink. Keep yourself hydrated, especially in summertime. It's so hot out there right now.
Water is so important.
Exactly.
Yet another reason to keep drinking water. Are there any other questions that patients should be asking their physicians about hemoglobin?
These days, many people have access to their own records already, right? To electronic medical records, so they can see the trend. And if the numbers are not following the trend, if suddenly you have one hemoglobin that's really off, ask why. Yeah, but also remember to provide the context. I know my hemoglobin is out of whack right now, but I was really sick last week. I caught a cold from my little baby. Do you think that could be affecting it, or maybe it's something else? Yeah. And more importantly is work with your doctor to explore the reasons why and to come up with solutions rather than jumping to conclusions. I think that happens to the best of us. And unfortunately, a lot of doctors, we jump to conclusions as well. And, we need to stop doing that. And then the best way for us to stop doing that is for us to have that open communication with our patients.
Absolutely. It's so important. Don't leave out any details. Always. I feel like my doctors are like my friends at this point. I'm like telling them all the details about my life because those are the things that are actually important and play a huge factor in how you feel, even though we might not be realizing it and just want to blame the hemoglobin.
Yep, that's for sure.
All right, I think that does it on hemoglobin. But I think now we need to get to another important topic, which is ferritin. The basics. Tell us what ferritin is.
I think the word evokes such emotional response from people, to tell the truth. I've seen people cry over ferritin. I've seen people jumping for joy over ferritin. If you want my 2 cents, I think ferritin is a little overrated. That's just my view. It's great. Again, I think the same principle applies. It's the trend. Ferritin fluctuates so much because it's what we call, in the medical parlance, we call it a acute phase reactant. So what it is that when your body is inflamed or when you have an infection, ferritin goes up. And often, if you're sick with, say, a cold or something like that, your ferritin is going to jump. A lot of patients will come to me and say, look, doctor, my ferritin jumped double the amount. It went from 1,200 to 2,500 from last month. I say, okay, hang on a sec. That's, again, very similar to what we talked about with the hemoglobin. Let's review the context, right? What has happened to you in the past week to a month? And then it turns out that the person has some sort of cold. And then you're like, that explains it. We don't have to go further into finding out why. However, if you continue to see that your ferritin continues to rise, right, or continues to fall, then that's a trend, and you can rely on that trend. And the other way I explain to people is like the stock market, right? Do you really care whether the Dow Jones goes below 10,000 or goes above the 10,000? Is 10,000 really some magical number? And 10,000 is not some magical number on the stock index. It's just a number. What's important, though, is the trend, right? Is it going up? Is it going down? That tells you how much money you're gaining and losing. So I think looking at trend is very important. Another way I look at ferritin is like this. Imagine iron being little kids in school, okay? They're just little kids. Now, if you want to figure out the number of kids in school, do you count the number of school buses or do you actually go into school and count the children inside the school? Exactly, because the bus can be full, can be half empty, and it could be completely empty. There's no kids on board, right? Because for whatever reason, maybe it's a snow day. So there's a whole bunch of buses, but there's no kids. And ferritin is exactly like that. Ferritin is that bus. And then if you look at how ferritin looks like under the electron microscope, it looks exactly like that. It looks like a ball, like a buckyball. And then inside there lays the iron atoms. So they are actually buses that transport the iron all across our body.
And the iron is found inside of ferritin.
Yeah, exactly. Yeah. So the ferritin is carrier. They are literally buses that buses the iron around. And the school that I'm talking about is the liver, because majority iron is stored in the liver. 70 to 90% of the iron is stored there. And so I say, it's better that we rely on things like MRI of the liver, aka Ferriscan, that's one of the other terms, or whatever term, R2 liver MRI. There's a whole bunch of, or T2 star liver MRI, whichever ones that your doctors use to test the amount of iron in your liver, that is far more important than, say, the ferritin itself. Because the ferritin, A, is susceptible to being affected by things like inflammation and infection. B is that it doesn't necessarily be carrying iron all the time. And by looking into the liver, into the school itself, we know exactly the number of children, we know exactly the number of iron in there.
Okay, so we know MRIs are important and those larger scans to track our iron, but when we're talking about a more frequent check,
yes,
ferritin is the next go-to, although it may not be as accurate.
Yes, exactly. That's a great way of summing it up. And again, remember, use it as a way to gauge the trend, right? Whether your iron is going up or down is a good way of gauging it.
And is there a specific range when it comes to ferritin as well, when we're looking at numbers?
Good question. You know what? It's funny because when you look at people, you'll be very surprised. Some people have very high ferritin and there is almost no iron in their liver. Like I'm talking about a ferritin of 3,000, 4,000. And then when you scan the liver iron concentration is 2 milligram per gram dry weight of the liver. Yeah, which is excellent. And then I have patients with a ferritin of 185, right? That's like super normal. I mean, to a point where you wouldn't even test it. And that person was never ever been on transfusion. Her liver iron concentration, 13.1 milligram per gram dry weight.
Wow. So it's a bit tricky.
Very tricky. There's some general rules as to saying that patients who are on transfusions, for example, the ferritin does track pretty well with their liver iron concentration. But in non-transfusion dependent thalassemic patients, especially alpha thalassemia patients, it does not track well at all. Ferritin often underestimates the true amount of iron burden in the liver.
Okay, so what is the important factor when it comes to ferritin levels? Why do we take them?
We take them mainly to see whether the iron is increasing or decreasing, and this in some ways helps us to adjust the iron chelators. So if we see the iron going up, we would increase the amount of iron chelators or maybe even switch iron chelators to adjust for that differences. If we see the ferritin going down, then we would adjust the amount of iron chelators to suit the trend. Another important thing is that it allows us to have a quick way, as you said, to look at the trend, the amount of iron, without having to resort to doing MRI, because it's simply not feasible. Even if we have all the money in the world, right, it wouldn't be feasible for us to do MRI every month or every 3 months. And then, of course, we have to think also that in many places in the world, MRI is not that accessible. And the accessibility is a factor as well when it comes to whether MRI is used often or not used at all in adjusting iron chelators.
Absolutely. That's a huge factor in a lot of how we treat our patients. So what is really the risk of having high ferritin levels?
The risk is not in having the high ferritin level itself, is the fact that there is high amounts of iron associated with that, right? It's a surrogate marker for iron overload. And the higher the ferritin, the more iron there is. Again, we need to look at that number in relation to the person's baseline. Because again, everybody is different. As I mentioned before, some people can have very high ferritin and there's no liver iron in the liver. Some people can have very low ferritin and can have a lot of iron in the liver as well. But as long as we have that sort of baseline measurement of how much iron is there in the liver, then we can gauge whether the iron is going up or down based on the ferritin.
And when the ferritin is rising or, like you said, not staying on trend, what would be the next course of action to get it to where we want it to be?
First thing is you need at least 3 numbers to make a trend, right? So meaning that if you have just 2 numbers, it doesn't really tell you where you're going at or which direction you're going at. And then second of all is once you do see that trend, of course, you talk to your doctors about if there's any other extraneous things that can be affecting the ferritin. For example, I have patients that were diagnosed with rheumatoid arthritis in addition to thalassemia. And sometimes you see the ferritin going up, but they are super compliant with their iron chelators. And then it turns out that the increase in ferritin is because their rheumatoid arthritis is not under good control. So sometimes the ferritin is going to reveal to us not just how well the iron is controlled, but also other types of diseases as well.
I've even heard that stress can cause your ferritin to spike. Is that true?
Yes, it's true. Yep, that's true, especially physical stress. I often joke that if I pinch you, then your ferritin is going to jump.
That easy, huh? No.
That's definitely true. And so, does that mean that you should live a stress-free life? I don't think it's practical for us to live a stress-free life, but I think it's just important for us to keep that in mind. Again, at the end of the day, we want our health to be better, and it doesn't necessarily mean that we want to keep that ferritin under control. That ferritin is only an indicator, a canary bird of the coal mine, of what's really happening in your body. And at the end of the day, we need to rely on things like the MRI of the liver, for example, as the final arbiter, as the final decision as to whether we're doing well with our chelation and what our iron balance is.
All right, that does it for part 1 of our lab test series, but make sure you stay tuned for part 2 coming up next month on Thal Pals, the Alpha Beta Revolution. Thanks everyone for joining us, and if you like what you heard, share it with your friends, share it with your family, share it with the world, and join us next time. See ya!